Welcome to the latest edition of Leadership and Culture in Healthcare. I'm Matthew Winn, our podcast host, and we are in we're in series, aren't we? Series 7, and we are talking to clinical leaders, people who lead change clinically, have national, local roles. And I am delighted to have an eminent geriatrician with us, Shelagh O'Riordan. Shelagh, why don't you introduce yourself, tell people what you do, and maybe how did you get to do what you're doing as well before we kind of start unpicking what you get up to day by day?
Okay, so hi everybody, my name's Shelagh. I'm a consultant community geriatrician. So I was a hospital geriatrician for many, many years. And in 2016, so exactly 10 years ago, I was doing the job and I thought to myself, if I don't do something different, I'm just going to be doing 10 more years of exactly the same, but more of it. So I thought, I'm going to try this community geriatrics stuff out and got a job in our local community trust. So I'm fully employed by a community trust for my clinical work. I was happily setting up a community geriatric service, which is all around proactive care and what we would now recognise as sort of that work, that close working in frailty in what we now would say is integrated neighbourhood teams, and supporting some community hospitals when COVID hit. And obviously at that very first time of COVID, you didn't want a load of proactive people turning up to your house to do comprehensive geriatric assessments or whatever. And so we pivoted the team to become a hospital at home service, which we did very quickly in a couple of weeks at the very beginning of March. And so now I run a big hospital at home service in East Kent, along with the restarted proactive care and the community hospital work. So that's my clinical work. It's probably one of the biggest hospital at home, certainly one of the biggest frailty hospital at home services in the country. And it's unbelievably successful. Not just because of me, but because hospital at home is unbelievably good. When I was doing that, then obviously there was a lot going on around virtual wards, which I think so virtual wards are defined as providing hospital level care in people's homes. And another word for virtual wards is hospital at home. So they're the same thing. It came from this idea of being the sort of virtual wards, virtual stuff that people did in COVID, but very quickly became much more than that. And you need to provide a hospital at home or a virtual ward. You need the things you get in hospitals. So a senior person who can make a clinical decision and agree a plan with the patient. You need the type of tests that you would have in hospital, and you need the type of treatments that you would have in hospital. And all those things either happen when you're still at home, so you never leave your home, and that would be called step up into a hospital at home, or step down, so you go to hospital, you get a little bit, but you come out earlier than you would normally. So if I use the term hospital at home or virtual wards, I mean them interchangeably. Anyway, how did I get into? So I have two other roles at the moment. NHSE is a funny place to work, and the places that you get employed by move around. So I was originally employed as I can't remember what my original title was, clinical lead anyway, as a geriatrician. And that sort of moved then into, I was employed by GERFT, etc. I call myself the clinical lead for out of hospital urgent care, because that's what I do. I advise and do the GERFT work for in that space. So that's the hospital at home work, but it's also how that works with for instance, urgent community response, and also these new things that are called SPOAs, which is single point of assessment, but is basically helping ambulances find an alternative to going to hospital. And then the other place that I'm in is that I'm the president-elect of the UK Hospital at Home Society. So come March, I will be the president of the UK Hospital at Home Society. And all of these things, how did I get here, Matthew, you asked me? It's sticking your head above the parapet, isn't it? It's really, really caring, which I genuinely do. I found this thing, which, I'd looked after people in hospital for many, many years. And I genuinely thought when I first qualified that the deconditioning that we saw was occurring because of the illness that the person had. And then when I started seeing people at home, I realised it wasn't. It absolutely isn't. it's the hospital part of it's the hospitalization, because it just doesn't happen at home. It almost never happens. And our average length of stay in a hospital at home for frailty is around 3 days, whereas in hospital it's between 9 and 11 days would be an average. So, and often what keeps people in hospital is their deconditioning, but it's also doing more tests than the patient actually may be needed in the first place, I think. So all of those things. So I genuinely cared, and that then led me to, to find places in which people wanted to listen, and I have found people genuinely wanted to listen. If you are a clinician who can see the big picture, then people need you, and therefore they find you as well. So that's sort of how I ended up where I am.
So many things to ask you, but let's just start with just help people understand a little bit more about hospital at home versus virtual ward. So you've pitched that at hospital at home, haven't you? Quite, and I'm in my book quite rightly. I slightly rue the day that when we were in NHS England, we had virtual wards, because I think it's a slight misnomer. But I think when I look around the country, and indeed I was thinking my dear mother-in-law came out of hospital not that long ago on a virtual ward. She was basically given a pulse oximeter, a temperature check, and a blood monitor cuff, and was then phoned up 3 times a day. You described needing specific types of tests, specific types of treatment, and senior decision making. And I think, well, none of that is actually what she had as a virtual ward, and I see virtual wards being bashed out at all. So do we need to kind of, in your mind, and this is kind of going off the topic of leadership, but do we need to kind of really focus on that intensity of support that hospital at home good services are about, and great risk taking, multidisciplinary, versus a myriad of care that can be done virtually nowadays? And they are different, aren't they?
They are. I always go back to, would the person be in hospital otherwise? And probably your mother-in-law, she may well have been in hospital otherwise. She was probably on an improving trajectory. But she probably wasn't better. They were probably worried that it could go either way. I'm giving them the benefit of the doubt. You're making a face, but I'm giving them the benefit of the doubt. And some people would say, well, let's keep her in hospital for another couple of days, monitor her, and if she's better in a couple of days, then she can go home. Oh, here's this thing that we can monitor somebody at home. Let's try that. So it might be that she would have been in hospital otherwise. The other thing I would say is it's the step up and the step down are very, very different, because you have to do the whole shebang at home, and therefore you do genuinely need all the kit and all the senior decision making that you get in hospital. Whereas if you go to hospital, you can get that bit, and then you can come home with the remote monitoring. I mean, the other place people do come home. So, for instance, most of our referrals in my service are about 70% of the patients never go to hospital at all, so they're all step up. But we do get about 20 to 30% of step down, and they often are people. Let's say they've got heart failure and they need ongoing IV diuretics, for instance. I mean, that is coming out of hospital, but that is definitely getting the treatment that you would have in hospital, and quite often that requires changes in doses, that requires further investigations, whether that's an echocardiogram or and some fairly intense monitoring. You need daily weights, you need your renal function checked, and so it's a spectrum. I think if you fit that criteria, would you have been in hospital otherwise? Do you need a senior level support? Do you need the sort of things you get in hospital and the sort of tests you get in hospital? Then I think that and if you even need one of those, you probably would have been in hospital anyway. So there are people who are running this on a very low risk discharge. So you might want to discharge somebody who a day or two earlier, and then they actually stay on what you might want to call a virtual ward for 10 days, getting this marvelous service but probably, not actually replacing hospital level care. So, I do lots of GERFT reviews of virtual wards and hospital at home. And that's where we would really push people to say, you need to up your acuity, you need to talk about risk. Risk is a really, really interesting thing, because what clinicians think are risky, or what, operational teams think are risky, and what patients think are risky are often very, very different. And many patients think going to hospital is incredibly risky. They recognise the things that they might lose. So they might lose the ability to walk, the ability to go to the toilet on their own, the ability to remember their wife's name, things that really, really matter to them. Whereas we might think the risk is, we've missed a high, a low blood pressure, when, in hospital we would have got it, or that, we could have identified this, that, and the other, an hour or two earlier. So the concept of risk, it's really, really interesting. And I think we are changing now away from, that idea of, I don't know. I mean, it's still nice guidance to say that everybody on anticoagulations who fall over and might have banged their head needs to go to hospital. But we know that is really risky for those patients. You might be living with advanced dementia in a care home, and going to hospital might be the one thing that just completely throws you. And we'll almost certainly do nothing about it, even if you've had a bleed. So that conversation about risk is changing, and we need to change with it.
And that's interesting, because I was going to ask you about risk, and one of the I think impressive things that Hospital at Home and some of the more mature virtual wards are doing is taking a more riskier approach. Just find that however you want to, but taking risk with people to support people in a more intensive way than they were probably pre-pandemic. And do you therefore think that your nature of clinical leadership and risk taking has changed since you've been doing this versus when you were a jobbing hospital geriatrician?
I think I might not have been a very normal jobbing hospital geriatrician.
so with that ride,
but
do you see yourself and your teams, because it's not just you, as you said, it's your teams.
I had literally no idea how well it would work. And I think that this is hard to do. I find it hard to get people to believe me when I say things, because they can't, if your normal is, in comes, albeit a very frail person who is very, very sick. And, they'd come in, they would be rushed to, the resus area of A&E. They would have, all sorts of people all around, loads of blood tests, a load of tests, lots of different opinions from different specialties. Is it heart? Is it wrist, chest? Is it, oh dear, their diabetes is up the creek, and you're waiting for opinions from lots of different people, and you're in hospital for a very long period of time, and you might come out of hospital, or you might die. If that same person is seen at home, they won't get all of that stuff. They won't get the 7 different opinions, and they won't get as many tests, and they might die, and they might not. And they might get better. And in fact, on the whole, they get better just as much, and they die just as much. And they frequently die at home in a peaceful way we frequently find, we get a referral of a very sick person, news score of 12 or, which is, pretty bad. And we'll say, do you want to go to hospital? Or do you want to take your chances, and do you want to stay at home? And if you die, where do you want to be? And they might say, I've always wanted to be at home, or they've already, they've got an advanced care plan that already says that, or their loved ones will say the same. And I don't know, maybe they do die a tiny bit earlier, but that's what they wanted us to do. And so I've sort of moved away from, I don't think that's risk, you see. I think that is doing what people want. There's no doubt about it. It's much, much easier to have a conversation about what somebody wants when they're still in their home than when they've got to hospital. And I struggle. I mean, I still do, I still work in hospitals, and the way I do it at home and the way I do it in hospital is very different. And it's just, in somebody's home, the power dynamic is completely different. They have control. They can make decisions. Whereas in hospital, they seem to instantly lose that traction, and then it's all about what we're going to do to you, and I don't blame, I know I have really fantastic colleagues who don't have that conversation. And that's, it is harder. It's harder in hospital. Apart from anything else, lots of my patients are hard of hearing, visually impaired. They're in a place with a sort of a pretend barrier, which is a piece of material around them. A curtain. And nobody can hear anybody. And, I'm towering over them, because there isn't any way for me to sit down and be at their height. And, and the whole thing is, it's a disaster. It may well be in a corridor.
And not the right place to be having that conversation in the first place, to be honest, because it's not private.
So it is very different. I just think I have a vision for the future, which I think is it's very different. But in the context of frailty, I think that we could provide nearly all the care at home. And if we could make sure that we supported carers, for instance. At the moment, we have very little support for carers. If we could have really good support for carers, and good personal care as well as medical care, I think we could do nearly everything. And obviously, I can't do a hip replacement or a broken hip at home, but there's so much you can do at home now. I feel like that concept of sending all the old people to hospital, and then all the people with frailty to hospital, and then they're the ones who all get stuck in corridors. I think we're going to look back on this time and think, my God, we could have been doing this all along, which is looking after them at home.
Yeah. And I think that's an interesting, it's a fabulous perspective, and absolutely right one. Thinking my aged father, 95. Oh, hang on, no, it's 95. So he's 95, not 94. I keep on saying that wrong. We had the conversation with him and about how he wants to die, and your point there was, does he want to die maybe earlier? But does he want to die in his domain without a set of interventions and treatment that he is happy with? And that's a good and correct conversation, isn't it? It's not the medicalizing what is, very much the end days of his life and making that as good as possible. And probably that's the difference, isn't it?
Yeah, it is. It's just because we can doesn't mean we should, is one of our team's mottos. Yeah. We have many. Our main one being, we ask you what you want, and try and provide it. But those are things that we think about a lot.
On that, with that kind of guiding star of we can support people living with frailty and very much towards the end of their lives in a different way. And we've probably now got the technology, the skills, not all of it very portable. When I see in my own organization, the geriatrician and the chief and the consultant nurse going out, I mean, they look like they're going for like a 4-week holiday with the amount of stuff they're going out with. I mean, it's not great for their musculoskeletal system, but put that aside, things will change and improve. You're a national and you're a local clinical leader. What's the role of clinical leadership to make that vision happen? And what's other people's roles? How do you do that, Sheila?
So I think that my role is to persuade people that it's possible, and lead people in that space. So that will be persuading other teams to do it. So and do it at the most efficient and effective way to get the biggest gain. In the NHS, we haven't got very much money, but we have got unbelievable skills and expertise. And so, and people who are allowed to do things differently, no matter what you say. So the UK hospital at home, so, the world of providing this at home in the UK is miles ahead of most other countries. And that's because of the NHS. So I think there's something about empowering clinicians to do it and giving them the tools and the things that they need to do it. And that I find relatively easy. I find people will sometimes be a little bit anxious around risk, and we have those conversations. They might not have been given the tools to do it. So they might not have, for instance, have point of care testing, but actually point of care testing makes the whole thing much, much safer and much, much more efficient. So, so there's all of those sorts of things. So there's that. There's a really interesting thing about persuading other clinical leaders that this is a thing. And I can't say, Matthew, that I have 100% succeeded in this space. Right. There's a whole world of people who just don't believe me.
In the geriatric world, or
mostly
in the
not in the geriatric
world?
Yeah, a little bit in the geriatrics world, but people in senior spaces in NHSE and in in societies, I'm not going to name them, but just really great, very senior clinical leaders. But because they haven't, there's a thing, isn't there? If you've designed something or discovered something or developed something, it's amazing, and I'm in that space, obviously. But some people just won't believe it, and we don't train people how to do this at all. We still don't. We don't, medical students now are not being taught how to do this. Nurses now are not being taught how to do this, and neither is the AHP world. I haven't quite got there. I'm getting there. I'm not quite sure why it's been so hard, and I think it's just a process. They say that it takes 5 years to change something, properly, and it's 5 years since COVID and 5 years since I've started talking about it. But maybe I'm expecting a bit much. But we're getting there. I think we will get there. I mean, just to get a GERFT team in virtual wards of hospital at home was quite a big deal. Now becoming, being part of the solution. I just told you that we came off a system call. The system I'm working in is in, whatever the worst stage of chaos in their A&Es is at the moment. And one of the first questions is what can our community partners do? How can you help us? That's quite unusual. And, and it is happening around the country now, and it didn't before. So maybe I'm just, expecting more and hoping for more. But it's, so there's that sort of leadership type bit as well. I think that's my role. Locally, I mean, I am the clinical director for the services across Kent. Locally, the clinical leadership has been, I often feel that I'm an ideas person and around productivity and, getting the best out of our team. I'm never going, my sister once said, you're not a farmer, Sheila. I'm not the person that you need to run a service day to day. That's not my skill. I'm the the pioneer, not the farmer.
And so that's an interesting observation, isn't it? So, you as a clinical leader, you can't be everything, can you?
No.
You can. You've talked about influencing. You've talked about making change. You've talked about providing the leadership to make it happen.
Absolutely.
Presumably, then you need some great nurse leaders, AHP leaders, general managers sitting alongside you as part of your team, but kind of fundamental parts of your team to make sure it happens, because you're not going to be the person that's doing the rosters to make sure that you've got 9 o'clock cover on, at night, and that actually people are trained to do it. You might do the training, but you're not going to kind of do that glue.
That's exactly.
I'm surmising, Sheila, but
I really like that triumvirate leadership thing. I mean, I could not do what I do without the ops support that I get. Both the ops, I mean, I call it, I don't know if it's called ops in NHSE, but my work in, my clinical work and my leadership there, I have, unbelievably good ops support that listen and make happen the things that I suggest, I suppose. It just sounds like I'm like bossing everybody around, but I'm not. But also in NHSE, we have the same type of person there who can put into writing, can make sure that this these ideas become a really amazing document that is usable, and that people can pick off the shelf and use to develop their services, etc. So the same, that in that triumvirate you have AHP and nursing leadership as well, and I think that as a doctor I cannot have their perspective and they cannot have mine. And we need, as a geriatrician, you would never imagine the MDT is so important. And so doctors are very important in the MDT. Sometimes people forget that. They think of an MDT as everything but the doctors, but we are very, very important in that space. But we do need leadership in, across things. So I'm a believer in the shared leadership that, and it's worked very, very well for me. I've been in clinical leadership for years, since I was, even as a trainee doctor, I suppose, and enjoyed it.
And then just flipping back to your national role, so GERFT, get it right first time, is that improvement, is kind of that tough data-driven, comparative, clinically led work that kind of goes on. And you've talked about influence in other clinical leaders in NHS England. I think my observation also from having worked in NHS England as the national body, for those that are listening for the English NHS, is it's about influencing though other people that actually are really important around standards, regulation, and other aspects, isn't it? So I think I've heard you mention the National Institute for Clinical Excellence, NICE, and that their guidance is perhaps dated. My words, not yours, in this respect. And part of, I guess, some of your role is therefore saying, come on, we need all of this facing in the right direction, because unless people feel safe from a regulatory, professional, leadership, college perspective, people won't kind of take the risks that you're quite happy to do. Would that be right?
Yeah, those are all essentials to get something, into the next space. And I mean, you and I were in virtual, what was then called virtual wards at the very, very beginning, weren't we? And I think it would never have happened if you didn't have really enthusiastic clinicians saying, my God, this is good. What, have you heard about this thing? But then, then us all pulling together to get the CQC on board, to get the Royal Colleges on board, to get NICE on board, to along with, all that sort of safety and governance things. How do you have governance across systems? If I take a patient from an ambulance, who holds that patient until I go? All of those sorts of things are really, really important. And that, as a clinical leader, I'm part of a team that gets that all signed and and done. It's never going to be just me. It's always, people come up with lots of different ideas. And I think, God, that's great. I hadn't thought of that. That I feel like that's part of the team of us all.
And I do think, for those that are listening, when people say, what do national clinical leaders do? There's a lot in there, isn't there, of what you've just described, because lots of that's about changing hearts and minds, showing people a different way, articulating it properly, enthusing them properly, showing them the evidence, developing the rationale, and then other people, because otherwise someone is going to say, and doctors do it, nurses do it, therapists do it, oh, it's not NICE guidelines, therefore I can't do it. Oh, my college says actually it's not a good way of operating, I am not going to do it. And I mean, I see, and I've seen you do it, but I've seen lots of national leaders spend a lot of time and effort behind the scenes trying to make that change, because that's some of the glue, or sometimes disablers, that actually get in the way of making clinical change care different, isn't it?
Yeah, definitely. It's really interesting. It's particularly, I mean, I don't know how it works in other countries, but it's particularly British, I think, that thing of tying it all up. And I think that's because we do have an NHS, but we do have a National Institute for Clinical Excellence. We have a national, the CQC is a national thing, isn't it? So we have to tie all of these things up. In other parts of the world, the idea of a step up, so people needing hospital and never going and staying at home, completely unheard of. Nobody would do it. But in the UK, right across the UK, we do that, and we do it at scale, and that's because we have the ability to do all of those things. So that's, I think it's a real advantage of the systems that we work in. I know I know we have our problems, but it's really, and it does it's allowed us to do what our patients want us to do.
Yeah, and I'm with you. I mean, there's so much hard work. We're recording this in the first week in January, and things are tough out and about. In all of our systems, it's very pressurized. But the fact that within, as you said, a 5-year period, we have now an embedded model of care that we never had before, that can only strengthen and develop, is fairly remarkable in many respects.
Absolutely. Yeah, absolutely. Yeah. And we should cut ourselves some slack and say, well done, shouldn't we?
Yeah.
I go to the, the World Hospital at Home Congress, and actually, weirdly, they don't think that what we do is very good at all, but they, that's to come.
Yes.
But we know it is. That thing about providing less is more is quite, I think that's a very mature, a very mature process that you might not get into, for instance, an American system, or in Singapore, or whatever, because that's more is more.
very much and very, very bed focused in that respect, and hence very much more expensive. And I think on that point, which is, I'd feel bad if I didn't mention that actually one of the chief flag wavers and supporters of this actually was Julian Kelly as the finance director of NHS England. Actually, without Julian, this would have never have taken off. He really got behind it and pushed it executive-wise, didn't he? Again, unseen, but could see the rationale and thought, yeah, this is the right thing to do.
Yeah, and published randomized controlled trials that proved that that it was cheaper. That research is the backbone, and they were pioneers. That research that I'm talking about, Sasha Shepherd et al. That was a pioneer work. That was looking at hospital at home starting in 2012. Recruiting patients in 2012. It was not common then, and yet they did that piece of research, which then came, the finance side of it came through just at the right time. So research is also absolutely essential.
So Sheila, we've touched on how to lead, how you clinically lead, and how you make that influence locally. How you're not the farmer, you are the I don't know if you are the farmer or not. There's an element of you being the farmer because you're at the front and making sure it happens. You're perhaps not the sheepdog anyway. They're doing the hard work behind the scenes. But talk to me about the role of clinical leaders in shaping the culture of how that team will operate, because my sense would be probably in the COVID times, you threw people together literally from all kinds of areas to try and do something, but then you would have had to make that sustainable. Then you would have had to embed it. You would have to do all the clinical governance, etc. So how have you shaped as a clinical leader the culture and the style of working that is prevalent today in Kent?
There is a personal side to it, isn't it? And my way of leading is leading by example. So I'll do it as well as I'm literally doing the clinical work with my colleagues, and I think that that's important. I think there's it's making people feel safe. So if they call me up with a tricky issue, I will help them solve it. And allowing people to be brave is really, really important. You're absolutely right. We had to practically backpedal a lot because we didn't have any of the governance behind us. We didn't have, I had, as you say, I had a few people leave, and that's right because the team wasn't what it was before. And, it's not for everybody. This, it's hard work. As you say, it's physically hard work. And it's, we do lots and lots of remote assessments, video particularly. And, some people just don't like doing that. And so in that, I'm really, if I say I'm innovative, that sounds, that I'm pushing my own boat, but I'm very innovative in finding staff in our team. I'll never advertise, for instance, I'll never think what I need is an ACP, or what I need is a specialty doctor, or what I need is, I'll advertise in all different spaces with the money that I've got. And then I'll just recruit the person that's best out of all those different career pathways. So that might not be who you thought you were going to get at all. And so also I find people and then I'll find jobs for them rather than the other way around. And I'll get people in all different ways. So I have almost no, we have one other consultant and myself in our team now. But we have 3 consultant practitioners. We have 25, 30 ACPs. We have 6 specialty doctors and 3 specialist doctors. So, that's a team that we've recruited across different places in different ways. And then we work almost seamlessly now with our urgent community response team. I don't like in the community particularly, you have to be one team in this space. Yeah. You can't be 2 separate teams. So, so that's, so I think what else did we do?
It sounds like though, Sheila, that you recruited for values, ethos, mentality, absolutely, and approach, not just for a standard set of skills there.
Yeah, absolutely. I'm looking for somebody who will fight on behalf of their patients, not somebody who finds that a very frightening idea. And so you get, I found some of the most amazing people, I think that the SAS doctor, the non-career grade doctors they're often people who are in that space because they want to do something different. That complete model of I'll do this, then this, then this, and this, and then I'll be a consultant or a GP doesn't suit people who are innovative. And so I found some really fantastic doctors in that space who now are, leading our services. The other thing I think I'm really keen on is the next generation of leaders. I feel like as I get older, that it's really, really important that I pass on my skills, but also make sure I've got people who can do what I do and have the opportunity to work at national and international and, the wider local networks so that they get all the opportunities they can. And so I, right across the full MDT, not just in the doctor space. I think that's really important as well. I'm 60 this year, and I'm sort of thinking about what's going to happen next. And I've got to make sure that this team that I've got is going to continue to grow and expand in the way that we talked about earlier, with the right people in it and the people with the leadership skills. And that's not just sending them on a course. It's giving them, being with them whilst they do things. So they do national things now that I pass to them, but with my support rather than. And I think that, I wish I'd had that opportunity when I was at that stage. Maybe I did to a certain extent. You can always look back at people who trusted you to do things. And so I really like doing that part of it as well.
Yeah. And just to, don't want to blow your trumpet so much, but you and others, a few other, geriatricians have really pushed this nationally to mean that therefore it's normal for geriatricians and nurse consultants, therapy consultants to be influencing and part of those conversations. And I think back even just pre-pandemic, there were probably 3 very part-time geriatrician older people's cares, and when we think about how much older people kind of use in our NHS and social care world, it's paltry some, but actually that has changed somewhat, hasn't it, to be able to be now more normal.
Yeah, absolutely. Yeah. And the concept of frailty and it being everybody's business is such a big thing. And I think the tide has turned. There was a stage in NHS you weren't really allowed to say that word. It sort of went a bit out of fashion, and it was like, well, no, we don't. We talk about multimorbidity, and but it's very, very different. And the geriatricians all got together, and we all, geriatricians are often very good leaders. I don't know why, and that whole narrative has changed to being really important now.
Yeah. So as we go into the end of this conversation, I mean, I could talk to you for ages, but we can't because I know you've got stuff to do clinically as well today. So you've talked about wanting the team to be stable, to succeed, to flourish, to kind of your continuity of leadership to move into the next fashion, whenever that happens. Obviously not pushing you out of a job. You clearly want to be boxing and coxing on an international stage, a national stage, which you will do as the president of the Hospital at Home Society, to make that a normal thing. What else would we expect to see Sheila doing over the next years? What's exciting you to kind of then keep on going and land a few more interested, innovative things before you finally do less clinically?
That's interesting, isn't it? I'm literally thinking about that at the moment.
Oh, you're right. Okay.
Yeah, literally thinking. So with the NHS plan, the 10-year plan, and the from hospital to community, there is a space, isn't there, where we're all saying that we need to provide urgent care out of hospital, but I don't think we've got to the stage where we're doing it, consistently, practically across the country at all. And so I think there is a huge amount more work to be done in that space. Also, I think what we haven't quite got our heads around is the money side of it, because it seems to me that you can take out a lot of work out of a hospital, and that doesn't necessarily mean that hospital feels the benefit. And that's partly because there is a general, but in where I work, we've taken out a huge proportion of the older people out of the hospital, and yet they're still struggling. So we need to work out how we how we move the money around. And I do think that if there are beds in a hospital, then we will fill those beds. Yeah. And corridors are just seen as beds, so they get filled. And so there's something about having that brave conversation about shutting beds, even though it feels like we're in a very tricky place. And I think you need very strong leadership in that space, and I think I would be very well placed to do it. Whether there is going to be a role in that, I don't know. There isn't at the moment. I'm sort of, as you put it, boxing and coxing to stay in this place. Nothing in NHS England and DHSC is permanent. My posts aren't permanent, and I, have to persuade people to continue me, to pay me. Then there's that more local thing. There is a possibility that I could. I have an idea. Where I work in East Kent, we have the largest population of frail older people in the whole of the southeast. We have the lowest rates of admission of frail older people, so we've already done well, but there's still a hell of a lot in hospital. So I would love to take out all the frail patients out of our A&Es and run something completely separate, out. So all the ambulance patients would come. I mean, in the ideal world, I think we could run it 24 hours a day. Just have a frail person's A&E, like a supersized frailty SDEC, but 24 hours a day, huge. We could do so much. I think that how we work with the ambulance staff is very, very innovative and not happening around the country. So there's some more. So there's all of these things are really great, and obviously I could say I've done a really great job and thank you very much. I'm going to go look after my new grandson, but also alternatively I could say I've got some more. I've got some more to give in this place. Yeah,
a few more cycles left in you yet. Yeah. And I think that sound very much like it's about the reality of living the 10-year plan, because we can all say we want to move care from hospital to home. Yeah, great. But actually it doesn't change until that system gets embedded with, going back to the early conversation, fabulous clinical governance, fabulous leadership, a well-trained workforce that takes risk and takes on ever-increasing volumes. And I'm kind of with your mentality, as closing hospital beds is an outcome of doing all those things properly, and then you have the opportunity to close down capacity. You don't do it the other way around, is try and close capacity down, because you won't do it unless you've got the alternatives there, will you? So there's a methodology to be developed there, which I think is absolutely the O'Riordan methodology. There must be some publishable work there, at least, to say how we can do it that way. Everybody gets their name on something at some point, so clearly you should be able to. And then last thing, Sheila, what would you say to people if they're listening to this, they're clinicians, maybe they're thinking of, is geriatrics the right place to be working in, or do they want to become put their head above the parapet and become a clinical leader? You said you've been doing it since training, so what kind of advice would you give people to kind of go down that route?
Can I give my advice to the women?
Yeah, go for it.
I just feel that it is still quite a tough world to be a leader as a woman in the NHS. I think in many, many places. I don't think it's just in the NHS. I mean, I had 3 children when I was relatively young. I worked part-time. I was probably one of the very first people to train part-time. And people told me that you can't really do that. That won't be a thing. And then people told me that, you certainly don't have time to do any leadership stuff. You've got to, focus on your clinical work, et cetera, et cetera. And I just kept going and I kept going. And then I have supported other people, other women who, a set of maternity leave is nothing in a career. If you find somebody who's really fantastic and they're, pregnant, you say, yes, please, I'm going to have you. How fantastic and lucky I am. And I just, to the women, don't let anybody put you down. Keep going. Keep, we really, really need to hear from you. We need you in this space, and you can do it. It is doable. My career has been very, very long in comparison to that time when everybody was saying I couldn't do it. And but I kept going, and I think that's really important that we can empower. Geriatricians are. I think it's something like 70% of geriatrician trainees are female. That it might be wrong. It might be 50 or 60, but it's very high. And in all of these places, NHSE has been quite tricky to be a female lead, I'd say. I notice it a lot, but I've got all the resources behind me to be able to keep going. and so will they.
Sheila, it's been really fascinating listening to you. Geriatrician, community geriatrician for 10 years now, hospital geriatrician. You've been involved in some of the bigger developments from national perspective, and now moving into this president-elect of the UK Hospital at Home Society, which I would really, for anybody listening, go and look at their website, get involved and look at their resources, because they've got some brilliant stuff and no doubt will continue to develop. I think we've heard about your passion, risk-taking, how you want to just completely turn care of frailty on its head and have it as a care at home local clinic, different approach, not a bedded approach, just because it's better for the person. You were fabulous in talking about risk is about listening to what's important to the person, because once you understand it from their perspective, your nature of risk changes, because actually it's what's right for them. And you've been great in talking about how you've made change locally, nationally. You want to move that on to other people and develop them. And I think this won't be the last time we will hear from Dr. O'Riordan, because I'm sure in your rest of your career, if you could get those things landed, the nation would be all the better for it. They're setting you a challenge, isn't it? Is how we can make the nation better at supporting older people to have dignity in death and a great end of last years of their lives. That's what it's all about. Sheila, thank you so much for your time and so much for your energy and your insights into clinical leadership on leadership and culture in healthcare. And I'm sure everybody will enjoy listening to your insights. Thank you.
Thank you.